So I thought I should release this video quite early, and I should actually record it before power decides to actually go. I know you guys now are getting even much closer to understanding the ECG. If you do understand the ECG, please comment "we are following" in the comment section below. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. This is my series on my YouTube channel where we look at medical topics in depth. In this ECG bootcamp, we look at how to interpret the ECG in 7 easy steps. In this particular video, we're going to be looking at left ventricular hypertrophy. In the previous video, we looked at right ventricular hypertrophy. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So if you haven't watched part 1 up until part 8, please pause the video, head over to the playlist, watch part 1 up until part 8, then you can watch this particular video. Otherwise, this will not make any sense. I'm serious. What are you still doing here? Please go watch part 1 up until part 8. Okay. So remember, in our 7 steps of interpretation of the ECG, step 1, looking at the patient and ECG details. Step 2, we determine decalibration. Step 3 is a general impression of the ECG. Step 4 is rhythm interpretation. Step 5 is QRS complex assessment. Step 6 is looking at hypertrophy. We looked at how to determine right atrial hypertrophy, left atrial hypertrophy. We looked earlier today, we looked at how to determine right ventricular hypertrophy. Now we're going to be looking at left ventricular hypertrophy. In the last step, we're going to be looking at how to determine ischemia and infarction. So remember these things, key points to remember. The first thing is that the impulse is going to start off in the right atrium from the SA node and spread and depolarizes the right atrium, and it also spreads to depolarize the left atrium. It also spreads from the SA node to the AV node via the internodal tracts. So depolarization of the atria is going to result in your P wave. This impulse is supposed to be taken to the AV node, which passes on the impulse to the bundle of His. There's a bit of a delay from the SA node to the AV node. That delay is what we refer to as the PR interval. Now, as this impulse reaches the AV node, it's going to be passed to the bundle of His. Then, of course, the left bundle branch will depolarize first, sending the signal towards from the left bundle branch to the right bundle branch. But in essence, there's going to be a vector, an overall vector that's going to be depolarizing the ventricles, moving in a leftward, downwards, and towards the front direction. So from 11 o'clock to 5 o'clock, that's our normal cardiac axis. Remember that as this is happening, if the electrical impulse is moving towards an electrode, this is going to cause a positive deflection in that electrode. If it's moving away from the electrode, it's going to cause a negative deflection. And the bulk majority of the muscle inside the heart is going to be on the left side. So the left ventricle has a greater influence on the QRS complex than the right ventricle. And if this is happening normally, your duration of your QRS complex is supposed to be less than 3 small squares. So it means that your QRS complex should be about 1 to 3 small squares. That's roughly around 120 milliseconds. The right ventricular lead is going to be represented by V1. So under normal circumstances, the wave of the QRS complex in V1 is supposed to be predominantly negative. So meaning that the S wave is going to be deeper than the R wave. We already established that in patients that have right ventricular hypertrophy, you're going to get these very tall R waves in V1, but we don't see that in left ventricular hypertrophy. I'll talk about that. So the left ventricular lead is in V5 and V6. So the height of the R wave is supposed to be less than 25 millimeters, less than 25 small boxes. In the left ventricular leads, they may also show a Q wave because of the way the septum depolarizes. Remember that the septum, the left side depolarizes first and sends a small vector towards the right side. So we expect a Q wave to be seen in the left ventricular leads. This is normal, but this Q wave must not be greater than 1 millimeter wide, so it must be one small box wide and within 2 boxes deep. So if you get an increase in the muscle mass of either the ventricle on the right side or the left side, this is going to actually affect the activity on that particular ventricle, and this is going to increase the height of the QRS complex and influence how it looks like in these particular leads. 2 important leads to look at: lead that is representing the right ventricle, which is V1, to some extent even V2, the one that is representing the left ventricle, V5 and V6. So remember that left ventricular hypertrophy is going to be as a result of either an increase in afterload, it could be due to hypertension, it could be due to aortic stenosis, or it could be an increase in the preload, which is aortic regurgitation. Whatever the case, the tension over the wall of the left ventricle is increased, so this is going to stimulate the left ventricle to increase in mass, so the cells are going to increase in size. We call this as hypertrophy. Remember, if these cells are increasing in size, it means they have to generate a much greater force, and for them to generate a much greater force, it means even the depolarization is going to be much, much greater. So what do we see when we have a left ventricular hypertrophy? We're going to see that the waves that are supposed to be generated by that ventricle are going to be very tall. So where do we look for these waves? So number one, we're going to get tall R waves in lead V5 and V6. These R waves are going to be greater than 25 millimeters in size. They're going to be greater than 25 small boxes. If we're looking at AVL, the R waves are going to be quite tall and they'll be greater than 11 small boxes. And in addition to this, you're going to have deep S waves in V1 and V2. This appears normal. If you look at your R wave progression, remember that in V1 and V2 the wave is supposed to be predominantly negative, which it is. In V5 and V6 the wave is supposed to be predominantly positive, which it is. But the positive wave that you get in V5 and V6 is going to be very tall. It's going to be greater than 25 millimeters. But remember that if we're just using this voltage criteria, in actual practice, if we're just counting the squares and determining the voltage, it may be quite difficult to actually make a diagnosis of left ventricular enlargement, such that with significant hypertrophy, we may see some other changes that may be associated, like T wave invasion in lead 1, AVL, V5, and V6. These are known as lateral leads, sometimes even in V4. And this makes sense because this is going to be indicative of a strain on the left side of the ventricle, which is known as left ventricular strain. We talked about right ventricular strain in the previous video, so if you are confused about that, it means you have skipped a particular step. And because now the left side of the ventricle is generating a much greater force, it means even the electricity is much more, the cardiac axis will be shifted towards that side, so there will be some sort of left axis deviation. So this is what it looks like. So as you can see here, in V2 and V1, you're going to have these deep S waves. In V5, you're going to have these tall R waves. And remember that this is representing a normal RS wave progression. And it's quite difficult to actually make a diagnosis of minor degrees of left ventricular hypertrophy on the ECG. Now, there is a criteria that I want you to know, which is known as the Sokolow-Lyon criteria. I know the word may sound so intimidating and you may think, what am I getting myself into? But it's a very easy criteria to look at. It's a criteria that you're going to be using, a voltage criteria that you're going to be using in order to determine whether there is left ventricular hypertrophy or there is not left ventricular hypertrophy. You're going to be using the waves in V1, V2 together with the waves in V5 and V6. So what I want you to do is that first you look at the waves in V1 and V2. You look at the deepest S wave and you measure the boxes. How many boxes is it deep in V1 and V2? Then you're going to come and look at V5 and V6 and you find the tallest R waves in V5 and V6 and you count the boxes and see which one is the tallest in V5 and V6. Then you add these two figures, the deepest S wave in V1 or V2 plus the deepest R wave in V5 and V6. If the answer that you get is greater than 35 millimeters, then it means that there is left ventricular hypertrophy. Very simple thing to follow. So here's an example. So if we look at the deepest S wave in V2, it's this one here. It's taller than, or rather deeper than these other two, this one here. So if you calculate the length of this, so we have 1, 2, 3, 4. So 5, 10, 15, 20. Okay? from the baseline, about 21, 22, 23, about 23 boxes in the deepest S wave here in lead V2. Then the tallest R wave in V5, which looks like this one, though it has been cut off at the end there. So we can still calculate 1, 2, 3, 4, 5, 6, 7. So 7 multiplied by 5, that's about 35. So 23 plus 35, you get an answer roughly around 58 millimeters or 58 millimeters rather. So this is going to be suggesting that there is some left ventricular hypertrophy. Now you also do get some features of left ventricular strain, and here I want you to be very careful because this may sometimes you may be confused with ischemia. So it's actually referred to as an acute coronary syndrome imitator because it looks like as if there's some ischemia, but it's not. There's just some strain pattern. So there is invasion of the T waves in the lateral leads. Like I already said, these lateral leads are looking at the left ventricle. So lead 1, lead AVL, lead V5, and V6. So remember that this is not going to be pointing you towards transmural ischemia. It's just T wave invasion with that sloping of the ST segment. It's different from the ST segment depression and elevation because in those you have a straight line. I'll show you the difference and how to distinguish between the two, but it's very difficult to distinguish between your strain patterns and ischemia on ECG, such that it's much easier that you actually decide based on how the patient is presenting. So this is what it looks like. So here we have our left ventricular hypertrophy with a strain. So as you can see here, these waves are very tall R waves. But we can see what is happening here. It's like there's a curvature and there's an inversion of the waves. But here it's more or less like a straight line. Again, you may think that this looks like a right ventricular strain pattern. It's very difficult for you to distinguish. But this one here, much easier. We can see that here there's going to be a curvature of this ST segment. Even here there's a curvature of the ST segment. These are going to be indicating strain patterns. If it's straight, this is going to be indicating ischemia. So here you have your ST segment elevation, ST segment depression. So strain versus infarction. Okay, so here's an example that I want you guys to work out. Pause the video, have a look at it, understand, use this your 7 steps to actually have interpretation, and you should be able to work this out. It should now be very easy for you to actually work this out. And here comes the answer. So the first thing is, of course, ECG details, which we don't have. The calibration is standard. As we can see, 25 millimeters per second. 1 millivolt is equals to 10 millimeters. Plus, we can look at these towers here at the beginning. 1 small square wide, 2 squares tall. We look at the morphologies. We can see that they are ugly morphologies here. They are broad QRS complexes. We look at the regularity. We come at lead 2, the rhythm strip, P wave, QRS complex, T wave, P wave, QRS complex, T wave, P wave, QRS complex, T wave. So it's a sinus rhythm. We calculate the rate. We look at the number of squares between the RR intervals. They're about 24. So 1.5 divided by 24, that's 63, roughly around 63 beats per minute. We look at our rhythm determination, again, still on our lead 2 rhythm strip. We look at our P waves that are present. They're married to a QRS complex T wave. P wave married to a QRS complex T wave. We look at our PR interval. Our PR interval is constant and it is normal within 3 to 5 small boxes. The QRS complexes are broad. As you can see here, they're wider than 1 to 3 small boxes. Remember what I told you. If your QRS complexes are broad, it means that there is a problem. It means that there is either a hypertrophy. It means that the conduction is being started off it could be that the conduction is being started off not from the SA node, but within the ventricular system, or it's being started off from the SA node, but there's some blockage somewhere. In this case here, we'll see what is causing this to widen, the QRS complexes to widen. We'll look at the cardiac axis. Lead 1 is facing upwards, lead 2 facing downwards, lead 3 facing downwards, lead AVF facing downwards. Cardiac axis is left axis deviation, which is significant. Check for any presence of any bundle branch blocks. Do we see any notched QRS complexes in V1, V2? No, we don't. V5, V6? No, we don't. So there is no bundle branch block. Because remember, if there's a bundle branch block, it makes it very difficult for you to determine whether there's hypertrophy or not. We look at our RS wave progression. In our limb leads, lead 1 is facing upwards, it is. Lead 2 is not. So it's already a poor axis, a cardiac axis. Even though the V1 and V2 are facing downwards, and V3 and V5 and V6 are facing upwards, this is still a poor RS wave progression. We look at the hypertrophy, we look at the presence of the P waves here. Are they broad? No. Are they bifid? No. Are they tall and peaked? No. In all the leads, they are not. Remember, you best see them in the inferior leads, lead 2, lead 3, and lead AVF. So P waves are okay. Then we now come to look at the ventricles. If the ventricles are enlarged, we look at V1 and V2. Remember, if it's right ventricular enlargement, we expect to see that they are tall R waves, but we don't see that. Instead, we see the deep S waves. You can see that they are deep S waves. So this already should hint us that there is some left ventricular hypertrophy. We look now at V5 and V6. They are tall R waves. You can see that this R wave here is even almost interlapping with that other R wave. So there are tall R waves in V5 and V6. There are deep S waves in V1, V2, and V3. In addition to this, when you look at the tallest R wave in V6, which is roughly about 26 millimeters, we add that to the deepest S wave in V2, which is about 47 millimeters. Our Sokolow criteria will be 26 plus 47, that's around 73. So that gives us that there is some left ventricular hypertrophy. We look at the presence of any left ventricular strain. Let's look at the left-sided leads. So beginning, of course, with our lead 2, is there any left-sided strain? No, but we can see, actually no, in our lateral leads, lead 1 is a lateral lead. So lead 1 here, we can see that there's some sort of strain here. There's inversion of the T wave and there's this curvature of the ST segment. There's left ventricular strain. We can see that in lead 1. We come to lead AVL, we can see that also in lead AVL. We come to V5, we can see that in V5. We come to Z6, we can see that in V6. So in addition to this, another significant thing that we are seeing is that there are some U waves. As you can see here, this is a T wave, this is a U wave here. There are some U waves that we can actually see on this particular ECG. So these U waves are going to be seen in this particular ECG. So how do we interpret that? This is a sinus rhythm at 63 beats per minute. There is some left ventricular hypertrophy with left ventricular strain. Very easy for you to interpret. We haven't yet covered ischemia, we haven't yet covered infarction. Coming to the next example, pause the video, interpret the ECG. You will find out that it's very easy for you to follow. And if you're not working these examples out, especially the very tough examples, in real life you won't be able to work this out. And here comes the answer. So again, we start off with our ECG details, which we don't have here, of course. Then we look at our calibration. It is standard. We can see that it's 1 box wide, 2 boxes tall, and of course the inscription here is normal, 25 millimeters per second, and the limb leads 1 millivolt is equals to 10 millimeters. If we look at the QRS complexes, they are wide, they are broad, and they're broad, and it's very slow. As you can see here, the distance is big, very slow. So they are ugly morphologies, they are wide, and they are very slow. The regularity, looking at lead 2, we can see that there is a P wave, a QRS complex, a T wave which is inverted, P wave, a QRS complex, a T wave which is inverted, a P wave, a QRS complex, a T wave which is inverted. So this is a sinus rhythm. We look at the heart rate, we can calculate the number of boxes. There are about 32 boxes between these RR intervals. So 1.5 divided by 32, that's 47 beats per minute. So there is some sort of sinus bradycardia here. We look at the P waves, we already say that they are present. We look at the PR interval, we're counting it's constant within 3 to 5 boxes, and it's constant. We do that for 3 consecutive waves. Our QRS complex is broad, as we can already see here. So it means there's a problem somewhere. Cardiac axis, lead 1 is facing upwards, 2 is facing upwards, 3 is facing upwards, AVF is facing upwards, normal cardiac axis. We look at any presence of any bundle branch blocks. There are no notched waves here in the V1, V2, V3, even in V5 and V6. We can't see any notching of the QRS complex, so there is no bundle branch block here. We look at the atrium, we come at the P waves. Are they bifid? No. Are they tall, peaked, and symmetrical? No. So it means that this one doesn't have any atrial enlargement. We look at the ventricles. What are we seeing on the ventricles? V1 and V2, very deep S waves. You can even see here the S wave in V3 is almost even falling off the paper here. very deep S waves. Very deep S waves. Then we look at the R waves in V5 and V6, very tall R waves. We can also see that there's some sort of right ventricular strain. How do we see this right ventricular strain? In V5 and V6, we can see that there is this invasion of the T waves. There's also this sloping of the ST segment. We can also see that there's this strain pattern in lead 1, lead 2, even in lead 3, and lead AVF. So there's some features of right ventricular strain. We can see what's going on here, that there are these peaked T waves that we can see in V2, V3. I'm not going to go into that yet, but we can already see that there are peaked T waves in V2 and V3. So this is, of course, a sinus bradycardia with a heart rate of about 47 beats per minute. They have left ventricular hypertrophy and they have left ventricular strain. I really hope you enjoyed this video on left ventricular hypertrophy. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.